Welcome to the Healthy and Helpful podcast, dedicated to tackling today's most pressing health challenges with practical solutions and inspiring stories. I'm your host, Dr. Bolanle Limann, and I'm thrilled to have you join us for this important episode on a topic that touches millions of lives worldwide: obesity. Obesity has become one of the most significant public health concerns of our time. The prevalence of obesity has nearly tripled since 1975. Today, more than 40% of adults in the United States are classified as obese, and the rates continue to rise globally, affecting both children and adults. Obesity is not just about weight. It's a complex, chronic disease influenced by genetic, environmental, behavioral, and societal factors. Beyond its physical impacts, obesity contributes to stigma, bias, and profound inequities in healthcare and outcomes. To help us unpack this multifaceted issue, I'm honored to introduce today's guest, Dr. Fatima Cody Stanford. Dr. Stanford is a pioneering obesity medicine physician and a leading voice in the fight against obesity. With over 200 peer-reviewed publications, Dr. Stanford is one of the most highly cited experts in her field. Dr. Stanford's academic achievements are remarkable. She holds a Bachelor's of Science and Master's of Public Health from Emory University, a medical degree from the Medical College of Georgia, a Master's of Public Administration from Harvard University, just to name a few. Her dedication to excellence has earned her numerous accolades, including the American Medical Association's Inspirational Physician Award and the Obesity Society's Clinician of the Year Award. Unfortunately, there was a technical issue we corrected. However, her first two responses are not up to the standard we would strive to provide. In this episode, Dr. Stanford will share her insights into the root causes of obesity, the latest advancements in treatment, and the importance of addressing stigma and inequity in obesity care. Whether you're a healthcare professional, a person living with obesity, or someone eager to learn more about this critical topic, this episode is packed with valuable information and inspiration. Hello and welcome. Dr. Fatima Cody Stanford, it is truly a pleasure to have you join the podcast today. I've had the pleasure of attending a lecture series that you've provided in the past, but many of the audience do not know you. So please introduce yourself.
Absolutely. I'm Dr. Fatima Cody Stanford. I'm an obesity medicine physician scientist at Massachusetts General Hospital and an associate professor of medicine and pediatrics at Harvard Medical School. It's a delight to be here with you today.
I'd like us to start by first addressing what is obesity and why it is such an important topic today.
Absolutely. This is a really important question. I'm glad you started off the podcast really asking that question. It's important for us to recognize that obesity is a chronic, relapsing, remitting chronic disease, and it is the most prevalent chronic disease in human history. It's a disease that's characterized by an excess storage of adipose tissue. And what is that? It's a storage of fat, a metabolically active organ that leads to over 200 other obesity-related complications. Diseases that we've heard of, like diabetes or high blood pressure, high cholesterol, polycystic ovarian syndrome, infertility, osteoarthritis, just to name a few. And what we do know is that this has become such a major issue that affects over 1 billion people worldwide. I've committed my life to caring with patients with obesity across the age spectrum as both an internist and a pediatrician. I do take care of patients from twinkle to wrinkle, and so my patients do range in age from 2 to 90 plus. And in many situations, I'm taking care of families really across the age spectrum, sometimes the children, the parents, and the grandparents, and in a few situations, even the great-grandparents, showing the high heritability of this disease process.
We hear a lot about obesity and, as you mentioned, multiple other diseases, heart disease, diabetes, etc. However, we hear less about cancers. Can you please educate me and our audience on the role of obesity and cancer risk?
Absolutely. That's a really important question. And you're right. We don't hear as much about obesity, but we do know that obesity, unfortunately, is causative of over 15 types of cancer. Some of the ones that you might be more privy to understanding is breast cancer, which of course is very common in women. Other cancers that we might see, prostate cancer, different types of cancers that you might hear of and not think that they're implicated in, lung cancer and other cancers. The reason why we think this is that excess adiposity that we spoke about a bit earlier, that excess metabolically active organ of fat, seems to set off a cascade of inflammation in the body, which of course is implicated in the inflammatory conditions associated with cancer and cancer development. And so we recognize that if we can somehow treat this excess adiposity that is often implicated in the development of cancer, that we can have a significant influence on the development of cancer types that are becoming, of course, more and more prevalent, not only here in the US, but around the world.
Thank you. And for the audience, you used the word adiposity multiple times. Can you please explain that to us?
Yes. So when I'm talking about adiposity, we're talking about adipose. Adipose is the excess fat organ, or the organ that is fat. So when we talk about adipocytes, we're talking about fat cells. A lot of people think that fat is just, something that looks unsightly. We don't like to carry excess weight. It makes us look uncomfortable, or we don't like the way it looks. But adipose is an actually metabolically active organ. And so when we talk about adiposity, I'm talking about that excess that excess organ, that accumulation of fat that may be in your midsection or around your buttocks region, or things that you're just like, gosh, I don't want this to be here, but it is an actually active, metabolically active organ. And so when I'm talking about adiposity, I'm talking about that excess accumulation of fat that you may not like, but actually recognizing that it is an actual organ.
Thank you. Thank you for the clarification. All right, the other thing we hear a lot about now is diets. There's a lot of public confusion over a variety of diets, keto, intermittent fasting, plant-based, etc., and various success rates. My question is, how can a person identify a diet that's most compatible with their health needs?
This is a really important question. As one of the 20 dietary guidelines committee members for 2025, I can tell you that we spent the last 2 years, looking at how diet impacts health. And I think it's really important for us to recognize that everyone has different dietary needs. And it's important for when I'm thinking about, particularly when I work with patients, finding the right diet for the right person for the longest period of time. And so I would say that this is really important to consider. I don't believe in necessarily dieting. I'm going to say that again. I don't believe in dieting. Because when you put yourself on a diet, it implies that it's something that's not for the long term. It's about finding something that is sustainable over the life course. Now, when we're talking about something like being a vegetarian or being a vegan, or someone that maybe decides that I want to eat a higher protein diet or something like this, these may fit certain needs that you have within your body. Someone that may be opposed to consuming, something that's from an animal source or something of this sort. But when we go into these things that are highly restrictive, things that can't be sustained over the long term, what we find is that we do something called weight cycling. And what do I mean by weight cycling? You go on a diet, you might lose weight for the short term. But what the brain does, and particularly the hypothalamic portion of the brain, there's a part of our brain called the hypothalamus, which is the most key part in regulating our weight. It recognizes that you lost weight, and what the brain does is it does something very important. It works to bring you back to your set point prior to that intervention. So you lose weight, you try some intervention with dietary strategies, and the brain is very smart, not just you're smart because you studied something. It knows to bring you back to wherever you were, but the brain is even smarter. In order to defend its set point, it usually will bring you to a weight that's higher than it was prior to whatever restrictive measure that you tried. And so this is really important. So I tell my patients, whatever we try, whatever you do in the dietary realm, let's pick something that you plan on sustaining forever. If that's not something you can commit to, then let's not try it.
That's an excellent point. I definitely agree with sustainability and practicality. So you've indirectly mentioned some of the myths. Are there any other common myths about popular diets that you think actually hinder weight loss or sustained weight loss, I should say?
Well, I think that this idea of like, let's look at the brand new year. I think we make these resolutions at the beginning of the year, and this is common no matter, what society we're in. We say, "Oh, at the beginning of the year, I'm going to make this resolution to eat a certain way or exercise a certain way." And we put these, I would say unobtainable um, really restrictive or highly exorbitant values that we choose to attain that are really out of reach for many of us. And when we fail, we beat ourselves up. It makes ourselves feel lesser than. Why do we do this to ourselves every year? Every single
Mm.
year, why do we do this to ourselves? Do we are most of us successful? The resounding answer is no. January 1st comes, maybe we're doing good for the first week, 2 weeks, maybe even that first month. But by the time we hit, November, I mean, come on, we're probably nowhere near where we set out to be. And so here is again this vicious cycle of, causing ourselves to feel really inadequate. And so these myths of like committing ourselves to these exorbitant goals that are unattainable really create a sense of worthlessness. And so I really want us to really be thoughtful about setting goals that are obtainable and achievable and ones that can be, that we can carry over the life course. And I really want to make sure that we're thoughtful about that.
Yeah, and you just mentioned a strong word, worthlessness. And the reason I say strong word is because of mental health and
Mhm.
stress and anxiety and other diagnoses that contribute to unhealthy eating patterns, which subsequently impact one's weight. Do you have any suggestions on how patients can identify and address emotional eating or stress-related eating patterns?
Oh, that's a very, very good question. And I'm thankful to have a full team that works with me at the Massachusetts General Hospital Weight Center. We have 5 full-time psychologists, PhD level psychologists that work with my patients that have, are dealing with these issues that because emotional eating can lead to what's the most common, for example, eating disorder. A lot of people think it may be something like anorexia or binge or bulimia nervosa, but the most common eating disorder in the United States is actually binge eating disorder. And so it can lead to something like binge eating disorder. But for those of us that are subclinical, meaning don't have these actual diagnosis of something like a binge eating disorder, that just have something like emotional eating, one of the things I ask my patients when they're starting as a brand new patient is do they eat when they're emotional, stressed, or bored? Um, I ask those 3 questions. And often they're surprised that I ask those questions because no one's ever asked those questions. So I would say ask yourself that question. Do you eat when you're bored, emotional, or stressed? And if so, what are the triggers for boredom, being emotional, or stressed? Identify what those triggers are. And when you identify what those triggers are, see how they can be modified. Because if you have this chronic boredom, being emotional or stressed, then we need to mitigate those factors that are contributing to them that may be leading to disordered eating patterns. Now, notice I said if they're chronic, but if sometimes we have acute stressors, what are those acute stressors that I'm talking about? What if there was a death in the family? What if there was something like a divorce or maybe a marriage or something like that? Something new that's exciting in your life. These acute stressors may lead to kind of short-term things that we, can get over very quickly. But if they're chronic patterns that we're noticing, we can work, to help mitigate those chronic issues once we've identified the things that have led to that boredom, the emotional patterns, and the stressors that are chronic in our lives.
Thank you. And for those who may, I mean, the words in the disorder, give people ideas. But for people who may not know, can you please just briefly define what binge eating disorder is?
Absolutely. So, binge eating disorder is characterized by a sense of kind of loss of control eating. This is if I were to try to interfere with you eating something, you might get a bit angry with me. You sense that there's a loss of control when you're trying to eat. You realize that you've eaten a significantly larger portion than you realized, a loss of control, whether it's at a particular meal time, at snack time, and you go on a binge, eating a significantly larger portion and on a chronic basis. This is something that, is a diagnosable condition, and we actually do have treatments and therapies. There's actually pharmacotherapy, which means medication that is available for treatment. For example, there is one medication that is available for treatment here in the United States. That is Vyvanse, that is approved by the FDA for the treatment of binge eating disorder, and that's prescribed by your doctor if and then you do actually have binge eating disorder. Now, I wouldn't say that pharmacotherapy is by far the only treatment. I do think working with a mental health clinician of some kind, in addition to using pharmacotherapy, can be useful in treating binge eating disorder.
So we've briefly talked about eating happens. With the increasing use of digital media, unfortunately, many of us are more sedentary, especially with our professions, and just less physically active. What role does exercise play in weight loss, and how can it be balanced with the busy lifestyle that many of us have?
Yeah, I'm glad you brought this up because a lot of people think that physical activity leads to weight loss when indeed it doesn't technically lead to weight loss. Physical activity leads to weight maintenance. And I'm going to give you a great example to help us understand this. While physical activity is one of my favorite pastimes, I get it in every single day. I think it's important for us to think about maybe our favorite sport. I like to bring up basketball because people, even people that aren't athletes, typically understand basketball very much so. So let's use a basketball person that people often know. I'm going to use LeBron James as an example because he's been around for quite some time, right? And we think about LeBron James, he's been playing in the NBA for a long time, and we can think about how aggressively he plays. We know he has to run up and down the court. He has to shoot jump shots. He has to shoot 3-pointers. He has to go inside the paint. He has to do all of these things. He's been playing long enough that his son is now playing with him in the NBA. But I want you to think about LeBron James, and I want you to ask a very important question to yourself if you're listening to me, and I want you to think about whether or not you think LeBron James loses weight between every single game. Is he just withering away before our very eyes? Or do you feel like he kind of looks the same? I mean, maybe he's gotten a little bit older as he's played in the league. I mean, he's, one of the oldest players in the league, but does he look statuesquely different? Or does his build look different? Or does he kind of look about the same? So I want to use that as an example or framework of thinking about how physical activity in all of our studies, our clinical research shows that physical activity helps us to maintain our weight. Now, if you're just completely sedentary and you begin a physical activity program, physical activity can potentially lead to some weight loss. But for those of us that work out, on a consistent basis, we don't go to the gym every day hoping to, oh God, I'm going to lose a lot of weight between session to session. It will just help us to maintain our weight. We can think about other people like a Serena Williams or other people that have been in the sport for a long time, whatever their respective sport is. And so I just want to make sure we emphasize the role of physical activity and weight regulation.
Thank you. I think that that's very important, and as you mentioned, maintenance. For those listening, it's still very important. I definitely encourage you to discuss exercise with your primary care provider. But as was just mentioned by Dr. Stanford, it's for maintenance and not weight loss. So I serve the underserved in central Pennsylvania, and socioeconomic disparities really impact access to healthy food, safe exercise spaces, weight loss programs, etc. What strategies can people use to lose weight in food deserts or areas where there's limited access to fresh produce? Do you have any ideas to share?
So yeah, it depends on really the degree of weight or excess weight that they carry. I always believe in using the right tool for the size of the problem, and that's a really important piece of the puzzle. So I think that that's something that we have to talk about right now. Despite the limitation of circumstances, it often takes a variety of tools. And so what do I mean by using the right tool for the size of the problem? If there's someone that carries significant excess adiposity, here we go again with that word, that means have severe obesity. Just looking at the environment around us is not going to be enough. That person will likely need to entertain something like bariatric surgery. That's something that may be seen as a dirty word when we're talking to patients, but I can tell you that when we have a significant issue, a severe issue, we have to use the biggest tool in our toolkit and our arsenal, that is bariatric surgery. Believe it or not, Medicaid and Medicare do cover bariatric surgery, is by far better covered than our anti-obesity medications. It doesn't quite make sense that that's better covered than medications, which are cheaper, but it is indeed the fact here in the United States that bariatric surgery is by far better covered, and is covered by both Medicare and by Medicaid. What are the differences between those two? Medicare is typically for our older adults, meaning those 65 plus. Medicaid is for those who typically have limited resources, of limited income. Let's talk about the next tool that I just mentioned, anti-obesity medications, meaning medications for those that may have moderate disease, have obesity, but not as severe as those that have the most severe disease. Medications can be used as a tool. We have generic medications, which are cheaper, and than those that are the ones that we're hearing about in social media and TikTok, et cetera, as much, where those can be very, very expensive, and we have less access to those tools. But you'll be working with your doctor, even if you're in rural portions of the country, you would still need to work with your doctor with these. And then let's get back to the thing that you probably wanted me to answer, which is how do we navigate in these areas where we have food deserts, food swamps? How do we access and mitigate the idea that we don't have as access to fresh foods and maybe physical activity? We have to become creative with using dry beans, legumes, lentils, etc., and using what we can in terms of frozen vegetables and fruits and things of this sort to make sure that we're meeting our nutrient goals, despite the fact that we don't have as much access to fresh fruits and vegetables, and proteins as we would if we were in a denser urban center.
Hypothetically, if there is a patient with severe obesity who has tried their best to make dietary changes, lifestyle changes, including exercise, what factors do primary care providers and obesity specialists consider when determining whether they recommend medications versus surgery versus a combination of the two?
Absolutely. That's a really, really great question. And, this is something that I definitely speak with patients about if they're brand new patients. I can tell you that one of the things that I really factor in is the severity of their disease. And I can tell you that this is an analogy that like I told you, I will often use is, if a foot of snow were to land in the middle of Boston, for example, on a winter day. What tool would I use for someone that has tried a variety of strategies? And if there was a foot of snow, and this is how I really kind of talk through this. So a foot of snow is a really lot of snow, right? And I asked them, hey, what will we use to get through this snow if we all need to get, on about our daily jobs? And I asked them, would it make sense for all of us in Boston to go get teaspoons out of our respective homes and try to scoop up the snow with the teaspoons? And the patients look at me and say, okay, Dr. Stanford, that doesn't make any sense. Teaspoon wouldn't be the best strategy to remove the snow. Okay, I was okay, well, teaspoon wouldn't make very much sense. Okay, well, what if we all run into our homes and all get our shovels and start, shoveling the snow out of the way because we just got this foot of snow? Okay, well, that's a lot of labor. We got to get everybody out and kind of coordinate that and get the snow removed. I'm like, okay, well, so what do you think the city of Boston is going to do, for example? And they're like, well, they're probably going to get the plows out. And I was like, yeah, that makes sense. So what am I speaking to here? We have to use the right tool for the size of the problem. If a patient has severe obesity, the right tool for that size of the problem would be something like bariatric surgery. Because we have to use the right tool for the size of the problem. If someone has more moderate disease, probably a better tool would be those shovels, which I refer to as now those anti-obesity medications. And for someone that has more mild disease, that would be lifestyle modifications, looking at more of our diet modifications, sleep modifications, exercise modifications to treat that level of disease. And so this is really how I have that conversation with my patients, using the right tool for the size of the problem. For patients that have very severe disease, they often will need all of those things combined in a stepwise fashion to really treat the level of disease that we're dealing with. And this really helps patients to really understand the treatment of that chronic relapsing remitting disease that is obesity.
Now, if the right tool is determined to be a medication, what do you share with patients in terms of expectations?
Absolutely. That's a really good question. And at this point, I really like to explain that this is very heterogeneous. I like to throw out big words. What does that mean? It is very patient dependent. So I can have a whole family that I'm taking care of. And I actually do take care of a lot of whole families where I'm taking care of 5 people in the family. And every single person in that family may respond different to the exact same medication. So I can tell them, like in a clinical trial, that maybe there's a 15% total body weight loss. What does that mean? So that means that if you carried 100 pounds more than you were supposed to have on your body, that means you would lose 15 pounds on average. But one person may lose 15 pounds, and that's 15 pounds over the course of a year on average. Someone else may lose 30 pounds. Another person may only lose 10 pounds, and another person may lose 45 pounds. So what I'm trying to say is that it's very patient dependent. And so what I like to let the person know when we start, that we can typically see how, at least if they are responding. Notice I said if they are responding after the first 3 months. Now, if they're not having any response, I can determine whether or not this medication is the right type of medication for them after 3 months. If they're not responding at all at 3 months, then that's probably not the right medication for them.
Thank you. So my colleagues and I have actually noticed less success in weight loss for some of our African American patients on weight loss medications. Do you have any thoughts or knowledge of medications being less effective in African Americans?
So I would say that's not necessarily true. We've seen certain of the maybe traditional meds, and what do I mean by more traditional meds? So if we go to medications like phentermine, topiramate, bupropion, and naltrexone, some of those medications being a slightly less efficacious in our patients of African descent, like myself. But I say that, and then I can tell you I've seen significant heterogeneity. Here we go with that word again. I have some patients that have lost like 60 pounds and then some that have lost 5, right? So now keep in mind that I have had 10,000 patients that I've treated with anti-obesity medications whereas someone that's in the primary care field may have had significantly fewer by which to judge this phenomenon. And so I think that it requires a lot more study. We have not seen, particularly with the GLP-1 receptor agonist, any significant differences with those of different racial ethnic backgrounds having significant differences in response to therapy compared to those of other racial ethnic backgrounds.
Well, that's good news. Hopefully, there will continue to be more clinical trials though as time goes on. So thank you for that.
Yes.
So another question I think is very important for people to know is, as you mentioned, this is long-term lifestyle changes. But just to reiterate that point, can you please share your thoughts on what patients should expect if they stop weight loss medications?
Very good question. So we're talking about a chronic relapsing remitting disease. If the medications are effective, notice I said if we stop using these medications, patients can expect to regain whatever they lost. most of the time. Notice I said most of the time. There are about 10 to 15% of the time where they will not regain um, weight that they've lost. So we like to continue these patients on the medications indefinitely because we're treating a chronic disease process. Notice I said 10 to 15% of the time where they will not regain based upon the studies we've seen. For example, Wilding and colleagues published the semaglutide studies. What am I saying when I say semaglutide? That's the trade name for Ozempic, or Wegovy. That's the drugs that we know about. Or if we look at Aroni and colleagues that published the data looking at tirzepatide, that's under the trade name of Mounjaro and Zepbound, we saw that not every single person regained their weight, but like I said, there was about 10 to 15% that did not regain their weight. And the reason why that is because we are no longer acting on those pathways of the brain that are controlling weight regulation when we pull those medications off of the patient, right? We are modifying brain and gut weight regulation with GLP-1s and GIP in the case of tirzepatide. And so when we're no longer acting on those pathways, we expect weight regain.
Thank you. I think that's very important for people to remember. Along those lines, in terms of taking these medications for long periods of time, are there long-term risks that are commonly associated with any or all of these medications?
No, so keep in mind the GLP-1s have been around since 2003, right? So we have data that's over 20 years old of patients that have been on medications of this class. For our more traditional agents, I have patients that have been on these medications for over 20 plus years. Keep in mind, drugs like phentermine have been on the market since 1959. So this predates someone like myself who was born in the 70s. And so we have really long-term data for the use of these agents. Drugs like topiramate, which are anti-seizure, anti-epileptic medications, have been around for quite some time. So we do have really lengthy data. It's just like using any other chronic disease agent, like a statin or other agent. We have to really think of these in the exact same light.
Thank you. All right. Another topic that I think many people utilize and talk about are digital health apps, wearable devices, virtual support groups. Are there any specific technology-based tools that you recommend for effective weight management or to assist in the process of weight management?
Well, it depends on what people like and what they have access to, right? So I think that there's really kind of like an ocean of potential things that people use. I think that a lot of people rely on things like the Apple Watch, right? Or if they are using a Fitbit or whatever it might be, I think that they use that mostly for keeping track of their exercise or logging their exercise. There's so many different tools that are out there. And I think it's, like I said, it just depends on what they decide. Hey, I really like this and I want to stick with this. But I would say that those two are probably the most commonly used, particularly for fitness tracking. There are several apps that are popping up where people are keeping track of their dietary habits. Some people are using continuous glucose monitors, even if they don't have evidence of diabetes, to look at their glucose excursions, postprandial glucose excursions, which means after a meal, to make sure that they're eating meals that align with really good metabolic health. And so there's so many to really capture that it's hard to kind of pinpoint or nail down one that's just like, oh, this is the go-to.
So, thank you for all this extensive information that you've shared. Are there any additional messages, words of wisdom, information that you'd like to share with the audience?
Yeah, I think the key thing is that just recognize that when we're looking at weight, obesity, first of all, obesity is not a dirty word. It is, a disease process that I treat. I think we have to treat people that carry excess weight, excess adiposity, the word you've heard me say a lot, that we have to treat them with kindness, dignity, and respect. And we have to recognize that it is a disease that I treat, and I've dedicated my life to treating patients with this disease process. Um, we also have to recognize that it is a chronic relapsing remitting disease. So just because you have bariatric surgery or just because you're on medication doesn't mean that voila, it's gone. It means that we do have chronic therapy that is needed over the life course. I said that I have patients that have been with me, most of them at least a decade. And the reason why is because we tackled most aggressively their disease initially when they came in, it doesn't mean that they're not ebbs and flows to the treatment. And so just recognize that this is how we do treat this disease. And if you're working with someone that really understands this disease, that it is a long-term commitment to the work. There is no easy way out. If you're using these additional tools, you're just using tools that do help assist you in the process. And so just begin to recognize and treat yourself with kindness and respect if you are someone that has this disease process. It doesn't mean that there's anything wrong with you. It just means that there's a disease that we now have really effective tools to help navigate.
It's been a great pleasure hosting you, and I truly thank you for your time today.
Thanks so much, BB.
This brings us to the end of another episode of the Healthy and Helpful podcast. As always, I want to thank you for being a part of this conversation. I look forward to you joining us for the next episode of the Healthy and Helpful podcast. Until then, be well.